Hi everyone, our group will be presenting information about small bowel obstructions. The small intestine is the organ affected by small bowel obstructions. It is the longest part of the digestive tract with a length of about 16 to 19 feet. It has three regions. The most proximal is called duodenum, which is attached to the stomach. The next 8 feet is the jejunum, and the last region is the ileum, which is connected to the larger intestine via the ileocecal valve. The walls of the small intestines have finger-like protrusion called villi, which produces wave-like movements known as peristalsis to move food further down the tract. The small intestine's major functions are movement, digestion, and absorption. The small intestine is considered the major organ for digestion. Small bowel obstructions, or SBOs, occur when one of the functions of the small intestines are impaired. It may be a partial or a complete blockage. It is one of the leading causes of hospital admissions related to abdominal pain complaints, and about 300,000 laparotomies or abdominal surgeries are done to diagnose or treat the disorders. It has life-threatening complications such as peritonitis due to leakage of colonic contents that causes irritation and infection, as well as bowel perforation when the obstruction is untreated. About 82 people die from SBOs per day. There are three different classifications that categorize SBOs. The first one is due to extrinsic etiologies, which comprises about 90% or the majority of SBO causes. With this kind of classification, the obstruction happens when the intestinal tract is being compressed or pushed from the outside. This is further divided into three different categories. The first one is adhesions, cancers, and hernias. Adhesions are the most common and occur as complications from prior abdominal surgery. So the more abdominal surgeries you get, the more adhesions you form. Usually they form after surgery as a scar tissue. They form inside the peritoneal cavity and may cause the intestines to kink and cause the obstruction. So when they form in between the intestines, they can make the intestines kink, and when they are in that scenario, it can cause the obstruction. Next one are cancers that can cause compression when cancerous cells metastasize, so they enlarge and compress the tract over time. So there's like a restriction that forms. Hernias, lastly, produce a sac that allows the bowels to protrude out, and may cause an event called strangulation. This can obstruct blood flow and can cause that part of the bowel to become ischemic. So no blood flow is going in, and eventually it'll become non-functional. That non-functional bowel causes the obstruction because nothing can pass through it. It can result to life-threatening complications such as septic shock. The less common cause of SBOs are of intrinsic etiologies, which are usually disorders that affect the integrity of the intestinal walls. Many chronic inflammatory disorders, such as Crohn's disease, cause the intestinal wall to thicken and slowly narrow the intestinal tract. Eventually, the tract can become impacted because of the restriction, and over time, it can cause the obstruction. The last classification are of intraluminal causes, and this affects the lumen or the opening of the intestinal tract. So this time it happens from the inside. Normally it happens when ingested foreign bodies that cannot be broken down or digested by the usual digestive processes cause the obstruction. And the usual location where this happens is the ileocecal valve, where the small intestine gets connected to the large intestine.
Signs and symptoms. Obtaining a thorough history and physical is essential in determining the degree of treatment needed. So a patient would come in having abdominal distension. They could have colicky abdominal pain, which is just a feeling of severe gas pains, nausea and vomiting. They won't have flatus or stool passing. They could have bloating, Their abdomen would be very tender, and their bowel sounds can start off high-pitched, but they will progress to be absent. Diagnostics. Labs that would be ordered would be a CBC, a CMP, and lactate. A low potassium and chloride levels and metabolic alkalosis may be noted in patients that have been vomiting. The blood urea, nitrogen, hemoglobin, and hematocrit may be falsely elevated due to dehydration. And if intestinal bacteria were to spread, an elevated white count or leukocytosis may be seen. If they have ischemic bowel, then an elevated lactate level may signal this. For imaging, they could have an abdominal x-ray. An abdominal x-ray with the patient in the supine position would show multiple dilated small bowel loops as the obstruction backs up, while the large bowel would show less or minimal dilation. Usage of abdominal x-ray is accurate in diagnosing small bowel obstruction in about 60% of the cases. Another imaging would be a CT. It's recommended by the American College of Radiology as the initial imaging to evaluate for intestinal obstruction in those with high suspicion of obstruction. The CT can be performed with intravenous contrast and or oral contrast. So CTs are highly sensitive in detecting obstruction and can identify the cause and level of obstruction for a majority of the patients. The sensitivity of a CT is 91%. Another diagnostic test that can be used would be an ultrasound. Although the sensitivity is close to 85%, factors that can alter readings include intraluminal gas and the patient's body habitus, which can obscure the ultrasound imaging. A better method to evaluate obstruction would be an MRI. However, due to the high cost, the need for technical expertise, and the amount of time required to perform an MRI, this type of diagnostic is not usually used for most patients to diagnose small bowel obstruction. Treatment and prevention. So first we'll talk about treatment. So there's medical versus surgical management. We have an NG tube to decompress. A majority of small bowel obstruction will resolve by simply placing a nasogastric tube and applying suction to decompress the stomach. This actually allows for the small bowel to shrink back to its normal size and rest. It can take a few days for this small bowel to decompress though. And signs that the treatment is working usually include the patient feeling less bloated and passing gas and stool. Other nursing considerations include the patient being restricted from oral intake, so the patient needs to be NPO. You want to start isotonic intravenous hydration. You want to have replacement of electrolytes should the patient's kidney function be safe, and a urinary catheter for close monitoring of urine output. Make sure the kidneys are working right. Antibiotics should be considered if the signs of infection are present, and medical management is effective in 40 to 70% of patients who are clinically stable. If signs of resolution of a small bowel obstruction do not occur within 3 to 5 days of medical management, that's when surgical exploration should be considered. So that would be the surgical management. If a patient clinically declines at any point, surgery should be considered as well. Signs of peritonitis, sepsis, leukopenia, acidosis, perforation, ischemia, and clinical decline would warrant emergent surgical exploration. And then prevention, that includes eating smaller meals more frequently, chewing food thoroughly, and drinking lots of water throughout the day, avoiding dehydration. You want to avoid or limit the intake of caffeine or other foods that can irritate the bowels, and exercising regularly can aid the bowel in regular digestive function. Patient teaching. So you want to teach your patient that the pain from the small bowel obstruction can take weeks to subside just because everything was stretched out and irritated in there. And you want to allow time for the body to heal, especially if you had to have surgery. It's going to take some time for all that to heal up and be back to normal. Some preventative measures you can take is make sure to chew your food well. Keep hydrated. You don't want to dehydrate and the stool get hardened in the bowel because that can cause an obstruction. You want to avoid high fiber food after a small bowel obstruction. High fiber foods can leave residue behind, and this can get caught in the bowels and cause another obstruction. And you want to also make sure you're exercising, moving around, just so your bowels don't stand still.